Hi guys. All right, so we're going to go over the prescription writing exercise that we did for hypertension. And I'll just point out some kind of key points, the way I would do it, trends that I noticed that you guys did on your assignment. And the point of this is to actually be able to use the information that we learn. It's one thing to learn all about the hypertension drugs. It's another thing to be able to actually apply that information to real life. So that's hopefully what we're going to learn to do with all of these exercises. So first, here's our case. A 66-year-old white female presents for ongoing management of stage 2 hypertension, which was diagnosed 4 months prior. Currently controlled on lisinopril 10 milligrams a day. Lisinopril was started at 5 milligrams daily and titrated up to 10 milligrams a day at the 1-month follow-up. Okay, that sounds good. Serum electrolytes are within normal limits. Patient experienced a 10% rise in serum creatinine, but serum creatinine has returned to baseline. Comorbidities include diabetes and dyslipidemia, which are controlled. No known drug allergies. Today, blood pressure is 128/78. Patient complains of a chronic dry cough that she's had for a few months. Patient denies any phlegm, otherwise feels well. She's afebrile. Okay, so numerous things jump out at me right away just to kind of evaluate this case. It's a hypertension case. So the fact that this is a white female is important because that controls how we're going to treat the patient. If the patient were black, we should be starting with a thiazide diuretic like chlorthalidone or hydrochlorothiazide, or with a calcium channel blocker like diltiazem, or amlodipine. Now, this patient is white, so we should be starting with something like an ACE inhibitor or an ARB, an angiotensin receptor blocker. So she presents for ongoing management. The patient has stage 2 hypertension that was diagnosed 4 months prior. For this patient, the patient has stage 2 hypertension, so she should have been started on a medication right away, which it looks like she was. I know that the goal for this patient is a blood pressure less than 130/80, and that's according to the AHA ACC guidelines. There are separate diabetes guidelines that go for a goal blood pressure less than 140/90. However, I'm going to go with the AHA ACC guidelines. So for me, the goal blood pressure is less than 130/80. Patients on lisinopril 10 milligrams a day. That is good. Lisinopril is an ACE inhibitor, which is a first-line medication for hypertension, especially in patients with concurrent diabetes. Diabetes is another disease state that kind of guides you towards using an ACE inhibitor or an ARB, something that affects the renin-angiotensin-aldosterone system. Lisinopril was started at 5 milligrams a day and titrated up to 10 milligrams a day. That's appropriate. A starting dose of lisinopril, 5 to 10 milligrams, is good. And it's supposed to be, the dose is supposed to be doubled every 4 weeks or so. So about a month, that's about 4 weeks. So 5 milligrams to 10, that sounds perfect. I'm not worried about the way the dose was titrated. Electrolytes are within normal limits. That is important. Remember that with lisinopril, hyperkalemia is a concern, right? Lisinopril causes an increase in potassium. So we have to monitor the electrolytes to make sure that they're okay, that there's no hyperkalemia. Patient experienced a 10% rise in serum creatinine. That is also okay. With ACE inhibitors, it's expected that the serum creatinine will increase when you first give it, but that increase should be transient. It should decrease back to baseline. It's okay as long as the increase is less than 30%. So 10% rise is perfectly fine. We didn't need to change the drug, and it's returned to baseline, so we're happy. Comorbidities are all controlled, right? Diabetes and dyslipidemia are okay. We don't have any allergies, so great. Now, that's the patient's history, right? Everything that's happened so far looks good. What did the patient complain about today? Where is she at today? Today, the blood pressure is 128/78. That is good, right? We're going to say that the patient is at goal. The patient complains of a chronic dry cough that she's had for a few months. Doesn't look like she has an infection. There's no phlegm. She feels good. No fever. This is a little worrisome. This chronic dry cough is an adverse drug effect of ACE inhibitors. So, and it does not go away. It's not something that, the patient just has to deal with for a few weeks and then it should go away, obviously, right? The patient's 4 months into therapy and they're still experiencing it. It also makes sense that the cough, there's a few things I'm looking at to see, okay, is the patient sick? Is it because of something else, or is the cough because of the ACE inhibitor? I am very confident that the cough is because of the ACE inhibitor. 1, the type of cough, chronic dry cough. 2, when she developed it. She's had it for, she says, a few months. She's been on the ACE inhibitor for 4 months. So it kind of makes sense that, as she started the ACE inhibitor, which remember increases levels of bradykinin, and that's what causes the cough, bradykinin built up, the cough developed. So the timing makes sense as far as it being because of the ACE inhibitor. There's no other signs that she has a respiratory infection or anything. No phlegm. She feels good. She doesn't have a fever. So I'm pretty confident that it's the ACE inhibitor that's causing this cough, which can be problematic. So let's see what the questions are to evaluate the case and what we're going to do with this patient. Because ultimately that's the goal, right? Like pretend this patient is sitting right in front of you. What are you going to do? Okay? What are you going to say to her? And what are you going to do with her therapy? First question, do you have any concerns about this patient's condition or drug therapy? Briefly describe your overall impression of the current situation. Most people evaluated the current situation just fine, or did this well and talked about their concerns well. Overall impression of the current situation is that the patient's blood pressure is well controlled on the lisinopril. Blood pressure is at goal of less than 130/80. So it's well controlled on the 10 milligrams of lisinopril. A couple students kind of got this mixed up. A couple students said, okay, so the blood pressure is, 128/78. So their pressure, the patient now has elevated blood pressure. The patient's diagnosis doesn't change, right? The patient was diagnosed with stage 2 hypertension. Now the stage 2 hypertension is at goal. You don't reevaluate the blood pressure and give them a new diagnosis of elevated hypertension. And the reason for that is that if you did, then their treatment would no longer make sense, right? So the chart that we looked at a chart where it had, normal blood pressure, elevated blood pressure, stage 1 hypertension, and stage 2 hypertension. Those values are just for diagnosis. Okay, after diagnosis, you just evaluate the patient based on their goal. Are they at goal or not at goal? And again, this is important because say we had a patient who had, a severe stage 2 hypertension, and we started them on 2 medications right away. Then we brought their blood pressure down and it was, in the elevated range. Then you look at the patient, you say, this patient has elevated blood pressure, but they're on 2 medications. That doesn't make sense. Why did we start them on 2 medications? Right? So then the treatment and the diagnosis don't match anymore. So once you make the diagnosis, that's the diagnosis. You then just evaluate the patient based on whether they're at goal or not. Another concern is some people were shooting for a normal blood pressure. Normal blood pressure is less than 120/80, right? That's normal. But once a patient has hypertension, we don't shoot for normal, we shoot for the goal. And the reason for this is the lower you shoot for, the increased chances that the patient will develop hypotension, right, as an adverse drug effect. And we don't want the patient to develop hypotension. That increases the chances of, them fainting, them falling, adverse drug effects like lightheadedness and headache. So studies overall have shown that the best risk to benefit ratio is targeting these specific goals that we mentioned in class. So you don't have to target a normal blood pressure. So for this patient, the patient is at goal of less than 130/80. They're tolerating therapy well in terms of kidney function, because their serum creatinine only increased 10% and it went back down to baseline, and electrolytes, because their electrolytes are within normal limits, meaning the potassium is okay, there's no hyperkalemia. However, there is an issue here, okay, but the patient has developed dry cough due to the ACE inhibitor therapy. That is concerning. It might sound like it's not. It might seem like it's no big deal, it's just a dry cough. However, this is a really common reason for patients not taking their medication. Imagine having a dry hacking cough all the time. It's annoying, it's frustrating. I talk all day for my job. If I'm constantly, I can't do my job well. So it might seem like it's not a big deal because it's not dangerous. However, it becomes dangerous if the patient stops taking their medication because of it. So my inclination is to change the medication to something that's equally as effective and does not cause a dry cough. That's an ARB, an angiotensin receptor blocker. However, instead of just automatically changing the medication, in my opinion, the best course of therapy is to give the patient the option. If patients have some autonomy, if they have a right to help guide their therapy and make their own decisions, they're more likely to stick to it and to follow that therapy. So I would present the situation to the patient and let them decide. The ACE inhibitor is causing the cough, but it's cheaper. The ARB is typically a little bit more expensive. So, find out, do you have insurance or not? It's a little bit pricier, but if you have insurance, that's probably not going to matter. And the ARB is as effective, but it does not cause the cough. Tell the patient, I prescribed the lisinopril first because it is less expensive and, there's a lot of evidence behind it. It is, typically a good drug, but you're unfortunately one of those people who happen to develop a dry cough with it. Now, I could change you to an angiotensin receptor blocker, and that drug does not have the side effect of a cough. Is that something that you would like me to do today? Giving the patient the choice then allows you to make decisions based on what's best for them, not what you think is best for them. In a space provided, write the prescription or prescriptions that you would give the patient to treat their hypertension, if necessary. Some patients just wrote for lisinopril, or some students just wrote lisinopril without discussing it with the patient. I would not do that. I don't consider that a great option. You at least need to discuss it with the patient. If you talk to the patient and the patient says, it's really not that big of a deal. I was worried that something was wrong with me, but if it's a normal side effect, it's fine. I don't care. I pay cash. I want the cheaper drug. Let's stick with what I have. Then that is okay. You can just rewrite the prescription for lisinopril. The 10 milligram dose is working perfectly. Just leave it at that and go on your way. But note that in the chart, discussed with patient, Patient is aware that, the cough is an adverse drug effect of lisinopril, still wants to stay with the med. Good. If the patient does not want to stick with the lisinopril and they want something that does not cause a dry cough, an ARB, right, an angiotensin receptor blocker, is a good choice. They are effective drugs. They're also recommended in patients who have diabetes with hypertension, which this patient does, and they are not associated with the dry cough. So I personally would start this patient on an ARB. Some students chose candesartan. That's an okay first choice. A lot of people chose losartan. Losartan is a good first choice as well. So write the prescription, write our patient's name. We didn't know the patient's name, but Jane Doe. Date of birth, we'll say 7/7/77. I guess that doesn't make her 63, but does that? Oh, no, it doesn't. 67, that makes her 63. So 7/7/67, whatever, today's date to 2021. Sorry, 1/20/21. Okay, important part. What are you writing, right? What's the prescription? So losartan. Now you could give 25 milligram tablets or 50 milligram tablets. The typical starting dose of losartan, if you look in UpToDate, or some prescribing resource, the starting dose of losartan is 25 to 50 milligrams. So we could start her on 25 milligrams. That would be a good first, starting dose, and then you can reevaluate her in a month. I'm going to start her on 50 milligrams. 50 milligrams is an okay starting dose, like it's a recommended starting dose. And the reason I'm choosing 50 milligrams is because the patient was on 10 milligrams of lisinopril. We had started her on 5 milligrams of lisinopril and we had to increase her to 10 milligrams to get the desired effect. So I'm going to just go ahead and start with the 50 milligram tablets of the losartan. Again, there's nothing wrong with starting with 25 milligrams. If you want to be safe, you can start with the 25 milligrams, and then again, you'll recheck the blood pressure in a month. If you have to increase it to 50, then you will. I feel comfortable going with 50, but there's not a wrong answer there. I'm going to dispense 30 tablets. I'm not going to give the patient a 3-month supply because I don't know how they're going to tolerate the medication. What if this is not enough and we have to give them 100 milligrams? The patient's not going to be, happy if she's got a bunch of extra meds sitting around, or if she doesn't tolerate it, if for some reason she has, increased serum creatinine too far and we have to change the drug, then she's not going to want extra months sitting around. Also, I want to make sure she comes back in a month so that I can check on her. If I give her 3 months, she can cancel the appointment and be taking this for 3 months when there's something wrong that she doesn't realize. So 1 month, 0 refills. So that I know she has to come back. The directions: take 1 tablet by mouth daily. And my name, my license information is already going to be on the prescription. My address, all that's already on the prescription, right? So losartan 25 milligrams, 1 tablet daily would also be okay. Again, lisinopril 10 milligrams, 1 tablet daily is okay as long as the patient okays it, knowing that it's causing the cough. Last thing, and one of the most important things, patient counseling. So what will you tell the patient about their treatment plan? I personally would tell the patient that, as we discussed, the lisinopril is causing the cough. So we're going to stop the lisinopril and change you to a new drug called losartan. Losartan is called an angiotensin receptor blocker, or for short, we call it an ARB. It works in a very similar way, and it has very similar effects to the lisinopril. So I anticipate that it's going to work just as well. The one benefit is that it does not cause the cough. So we should, over time, over the next week or so, you should see that cough start to disappear. So that will feel better. The losartan does have some of the same risks for side effects that we saw with the lisinopril. There is still that risk for angioedema. Remember, that's the thing where your face and throat can swell up. Now that's very, very rare. It's actually much less likely with losartan. So losartan is a little bit safer as far as that is concerned. Make sure you tell them about other side effects as well, right? This losartan still has the possibility to increase your potassium. So make sure you don't take potassium supplements. Tell the patient, just like with the lisinopril, this losartan is taken once daily. Try and take it at the same time every day. That way you don't forget to take. I would recommend to the patient or continue to tell the patient about all of the other lifestyle things that they need to do to help improve their hypertension and to try and decrease other comorbidities from developing. So tell them, remember that this medication is wonderful, but it's not magic. You still have a big responsibility in maintaining your health. So all the things that we talked about before are still important. Making sure that you get 90 to 120 minutes of exercise each week. Following the DASH diet, right? So making sure you're limiting your sodium intake. Limiting alcohol, making sure, so less than or equal to 1 drink a day for women. Making sure that you are not smoking, right? That there's no cigarette smoke or tobacco products, no illicit drug use, etc. Weight control, all of that counseling is still important for the patient. And then make sure you stress to the patient, the reason I'm telling you all of this again and making all of these recommendations is that it's really important to control your blood pressure. You might not feel bad because of high blood pressure. A lot of patients don't feel it. There's no symptoms for most people. However, that hypertension is secretly going around your body and wreaking havoc. It can damage the retina in your eye. It can damage your kidneys. It can cause lots of other problems. So it's really important that we take this medication and make sure we keep it under control. Also, make sure you talk to the patient about the importance of home monitoring of their blood pressure. Something that I saw one of the students mention that's a really good thing is to make sure they know how to use the blood pressure machine, right? Don't just say, don't forget, monitor your blood pressure at home and keep a log and bring it next time, but make sure they actually know how to use it. That's incredibly important, okay? I'm trying to think everything. So side effects, right? Make sure you talk about the side effects like hyperkalemia. Make sure they don't take potassium supplements. There's a possibility of altered taste and rash. They didn't experience that with lisinopril. They're probably not going to experience it with losartan, but it's still a possibility. The potassium is really important though, because that's something that they have an action for, right? They have to avoid potassium supplements. Make sure you talk about all of the lifestyle changes and why that's important. Make sure you've got them monitoring their blood pressure at home and bringing the log to the next visit. Also, make sure they know that they do not take both drugs together. Okay, you're not adding the losartan. You're taking the lisinopril away and then giving them the losartan, right? You're not adding them together. They're not supposed to take both together. That's really important for them to know. If they experience any problems at all, they should call you. They're going to need to go get lab work in 2 weeks so that you can make sure that everything is going well and that they're not having any bad reactions to the losartan. And then you'll have them come back to the office in 4 weeks so that you can check their blood pressure, go over their lab results with them, and make any changes if necessary. So that answers the following question. What monitoring and/or follow-up will you use? You need to monitor their serum creatinine again, right? Remember, we did that when we started the lisinopril. Now that we're starting a different drug, we need to do that again to make sure that this losartan is not going to interfere with their kidney function or their potassium. So whenever you start one of these drugs or change the dose, you need to monitor kidney function and electrolytes, as well as, of course, blood pressure. But they need labs for kidney function and electrolytes to check the potassium in 2 weeks. As long as you'll get that lab work, and as long as it's normal, they don't have to actually come in 2 weeks. They can just get the lab work. You can review it. If it's abnormal, of course, you want to call them in so that you can make changes. And then in 4 weeks, they're going to come in for their blood pressure evaluation and follow-up. If they're good, if they're at goal, and this is another thing, I really liked it. Some students kind of went out further and said what they're going to do next. And that was good. It's good to keep that in mind so you know what your goal is and where you're headed. In 4 weeks, if they come back and they're at goal, then that's wonderful. Just kind of evaluate or tell them the importance of all of this. And then the next visit will be at 3 to 6 months. If they come back and they're not at goal, then you're going to be able to titrate the dose, right? You're going to increase the dose of the drug. So then you'll increase the dose, and then you'll have to have them come back again in 4 weeks, right? So the 4-week follow-up is going to be important until they're at goal. Once they're at goal, then that follow-up can increase to every 3 to 6 months, depending on the patient, how old they are, their comorbidities, how closely you need to keep an eye on them. Okay? All right. That was really good. You guys did a really great job. There were just little tiny things that I picked at as far as, making sure, you say at goal and what those actual goal values are. Another thing I was picking at is don't just keep them on that lisinopril. You got to talk to them about it. So that they understand that the lisinopril is causing a cough and there are other options. They need to know that there are other options and, they need to make that choice. Otherwise, your counseling points were really good. I was really impressed with the way you guys did it. So we'll do another one next week. We'll do one on heart failure. All right, bye.